So I'll try to go quickly to make up for the poor chairmanship. First thing I got to point out is the question mark. I don't know whether the pointer's working here. Oh, it is awkward, but the question mark. So I'm not advocating for use of low-cost alternative PrEP, but I'm just trying to start the discussion and get a sense from cleverer people than me about what people think about this as an approach. Just some disclosures. So just in terms of background, Lenacapavir approved very recently in June for 6-monthly subcutaneous pre-exposure prophylaxis. But with the subcutaneous Lenacapavir, it takes time to reach protective concentrations following injection. So there's 2 options available for initiating long-acting LEN PrEP. The first option, as studied in the PURPOSE trials, is a 600 mg oral LEN on days 1 and 2, with 927 milligram of the subcutaneous LEN also given on day 1, so a total 1200 mg oral dose to initiate Lenacapavir PrEP. The second option, which was studied in the treatment trial, Capella, is 600 mg oral LEN on days 1 and 2, followed by 300 milligram oral LEN on day 8, with 927 mg of the long-acting Lenacapavir on day 15, so a total of 1500 mg oral dose. So the need for the oral LEN when initiating long-acting Lenacapavir PrEP does pose 2 challenges to rapid adoption in low and middle income countries. Which is really where long-acting twice-yearly Lenacapavir can have a huge impact. So these challenges are generic manufacturers obviously have to develop, study, and gain approval for 2 products rather than just 1 product. So they're going to have to develop analogous products for the oral Lenacapavir as well as the long-acting injectable Lenacapavir. Second problem is that since you're only using the oral Lenacapavir in order to initiate the long-acting Lenacapavir, there's a very small market size currently for the oral Lenacapavir. And so that, that's a difficult thing for the generic manufacturers to engage with. And potentially there are implications for downstream costs to the healthcare systems. We know there's multiple low-cost oral options already available for a pre-exposure prophylaxis, and so the current work analysed publicly available Lenacapavir pharmacokinetics with and without oral LEN initiation to estimate how long oral PrEP with a low-cost alternative would need to be given in order to cover that period while the injectable Lenacapavir reaches the target concentrations for prevention. So we had 2 primary data sources. Both the publications are shown in the bullet points here. We had the LEN plasma pharmacokinetic data for both of the initiation options, and we also had the Lenacapavir pharmacokinetics without oral initiation. And the 2 graphics we used are shown here at the bottom of the slide. So all we did, pretty simple, was digitize the data from those 2 graphics. We also digitized the measures of spread, so the confidence interval areas for option 1 initiation and the error bars for the LAI only PK. And as already described by Mark, we used the IQ4 as the target. Probably don't need to tell this group this, but I often get asked how accurate is digitization from a plot. Thankfully, somebody studied it, and it's highly accurate. And the specific software that we used is included in this graphic just to cut it. It's highly accurate, highly precise, 99% accurate. So these are the primary results. We just replotted those data on the same graph to facilitate comparisons. And just a couple of things to note. So for both option 1 and option 2 oral initiation, plasma concentrations exceeded the IQ4 on day 1. That's a no-brainer. In the absence of oral LEN at initiation, the LEN plasma concentrations did not robustly achieve the IQ4 until 35 to 42 days post-administration. And just to highlight that, at day 21, the first of the participants started to reach IQ4. 7 days later, the median concentrations hit the IQ4, and the majority of patients went above the IQ4 on day 35, with all participants being above IQ4 by day 42. Following day 42, as you can see by the data after the green arrow, plasma concentrations were similar between the different dosing schemes until the end of the 6-month dosing interval, indicating if you're going to bridge, you don't need a bridge for subsequent doses, and that's clearly of interest. We did do a non-compartmental analysis of the digitized data as well, and you can just see here AUC from day 42 to 6 months after administration, and the comparability in the exposures across the 3 groups. If anything, without oral initiation, the AUC was higher, and a very similar terminal flip-flop half-life. So there are some limitations. Pharmacokinetic data were only available for a very small number of participants. So it was N equals 31 for option 1, N equals 14 for option 2, and only N equals 8 without oral initiation. So care should be taken regarding the generalizability of this analysis. While the data digitization has high accuracy, the figure quality wasn't brilliant. We have less certainty around the error bars on the data, so so important to point that out. We're comfortable, however, that it's sufficient quality for interpretation. Interpretation should probably consider as well that IQ4 was developed as a treatment target, not as a prevention target, although it has been used, as Mark described, as a target for pre-exposure prophylaxis. In any case, a higher target is unlikely to be required for prevention compared to treatment. So just some considerations really to maybe spur some discussion on this. Oral LEN is also likely to have other uses, and we've seen some other data at the conference this week, such as during TB treatment or during LEAT dosing of the subcutaneous LEN. I don't think there's any obvious reasons why a low-cost alternative couldn't be given in those situations as well, FTAF, FTDF, where there's no interaction with the rifamycins, for example. Important to recognize, though, that future expanded use of oral LEN in low and middle income countries, both in treatment and in prevention, is likely to increase demand and change that value proposition for the generic manufacturers. So important to highlight that. Unlike oral LEN, the low-cost alternative would require daily oral dosing. And probably the most significant challenge to the use of low-cost alternative would be adherence during that period early in initiation. And of course, the adherence risk escalates with the duration that you're giving daily oral dosing for. Don't need to say, obviously, there's currently no clinical trial evidence to support initiation with an alternative oral dose. The risk of PrEP failure and of resistance selection in individuals and in a population level are highly uncertain, and so we would need to give that some considerable thought. So just to conclude, limitations understood. The absence of a meaningful impact of oral LEN on the SC profile supports the feasibility of using a low-cost PrEP alternative. For the IQ4 target to be achieved, however, we'd have to do that for 35 to 42 days. And so we need careful consideration of adherence and the associated infection and resistance liabilities. And maybe there's a case for a modelling exercise to really try and get a handle on how big that risk is. And then just to finish, I had a chat with good friend Marta Buffy to a coffee, and she said, what about initiation with CAB-LA? So just to seed some discussion there on that too. Okay, thank you.